Welcome. Sorry, I was trying to get the tech figured out. I'm Dr. Laura Rowley. I'm the Assessment and Testing Program Director at UCEBT, and I'm so grateful to be joined here today by Triona McMaster, who is the owner of Lifestone Counseling Center and an LCSW. So this is a very special presentation today. If you've never joined any of our events before, welcome. And if you're an old, veteran to our events, welcome back. This event is cool because we are able to be accredited by the APA to offer CE events. So that's pretty exciting. And this talk is also pretty special because the topic of DID was a highly requested topic when we asked for community feedback about what kind of events do y'all want to hear more about and what are you guys interested in. And so we're really excited to do this today. Before we really get into it, we have a few disclaimers and things like that. So conflict of interest, there's no conflict of interest. We already talked about where the proceeds of the talk are going to go, some accuracy, utility, and risk. We'll do our best to kind of discuss what the limitations and all of the research we're presenting are, and we've linked all of our sources. And obviously just know there's maybe an ethical risk if you apply materials to this in a way without proper training or supervision. This is kind of our overview of the day, and we're going to, whichever one of us between me and Triona are not presenting, the other one's going to kind of follow the chat and see what questions come up for you guys. We'll pause at the end of each section to make sure we didn't miss any questions, so feel free just to keep throwing them in there. And yeah, we'll get going. So I am going to start us off. We're just going to talk about basic definitions and origins of dissociation broadly, as well as DID. And before we really dive into that, I just want to highlight these organizations. Like, if you are really interested in doing more of the research or training or keeping up on the latest research, these organizations are a super helpful place to go. It's where we're members, or where we've got a lot of our research or papers that we're linking here. So I highly recommend checking these places out. And as I said, we've linked all of our resources at the end as well. And then Triona is going to kick us off with describing dissociation.
All right. Good morning, everyone. So what is dissociation? I mean, right there, we've got the definition. So problems with memory, identity, emotion, perception, behavior, and sense of self. Dissociative symptoms can potentially disrupt every area of a client's mental functioning. So that's the technical, definition of what dissociation is. However, when I'm talking to my clients about dissociation, giving them psychoeducation, I usually just say, physically, I'm here. Mentally, I'm not here. My brain is somewhere else. And that's the basic definition of what dissociation is. However, there are generally three different types of dissociation when we talk about it. So the first one is depersonalization and derealization. And those are often said jointly and together. And so depersonalization is basically the client doesn't feel connected to themselves. They feel detached from themselves. And then derealization is the client feels detached from the world around them and from everything that might be happening. So I just wrote down here some common statements that clients might say if they're experiencing depersonalization or derealization. So clients may say things like, I feel numb. I'm trapped in I can't talk, in an invisible bubble. I feel like my memories aren't mine, or time seems to stand still. So those are common things. And then we've got dissociative amnesia. And just like how it sounds, it basically is that there are lapses in memory or lacks of memory. And these could be specific or general. So they could be specifically like, I don't remember when ABC happened, or it could be more general of, I don't remember certain times of life, or just kind of in general, I don't remember names, I don't remember circumstances. So again, clients may have say things like, when did I buy that? I don't remember buying that. Or I don't remember that happening. Loved one may say, oh, you did this, this, and this. I don't remember that happening, or I don't remember saying that. Or they may say things like, they acted like they met me before. This person saw me on the street and they acted like they knew me, so I must have met them before. They just don't remember maybe meeting that person. So that's the second type. And then the third type is dissociative identity disorder. And so when clients come in, they may say all of these statements, or they may say some of these other ones like, I'm not sure what's going on with me. They just feel very confused about themselves or about their experiences in life. Or they may say, I have these weird episodes. They may not know exactly what's going on with them. Again, maybe this general confusion. Or more broader statement, I don't remember my childhood. I've had clients come in and they're like, yeah, I don't remember anything under the age of 16. And I'm like, oh, okay, we got some dissociation going on here. And so those are just kind of some general statements that you're going to maybe hear from some of your dissociative clients. All right, and this is the dissociation chart that we use quite a bit at Lifestone. And I use this when I'm just giving some psychoeducation to my clients about what dissociation is. And I feel like that's very vitally important to make sure clients have a general understanding of what dissociation is, so that it's not scary, there's not a taboo about it, it's something everybody does and we can normalize it. And I like using this chart because it gives us a common ground of understanding for me and for them so clients can basically talk about what they're experiencing and what their dissociation looks like for them. So we've got, sometimes I feel like I'm floating. I feel split apart, or like I'm someone else. I feel like I'm in a haze. I feel like a robot. I feel numbed out. I feel like I'm daydreaming, or I'm disconnected from my body, or I can't remember things. And some of these statements could be said also when clients experience not just dissociation, but kind of more mild dissociation that goes with depression sometimes, feeling like a robot or in a daydream or numbed out. So that's why I like using this, because we can talk about, okay, dissociation on a less or more mild sense of like, okay, I feel like I'm floating, which is pretty mild dissociation, all the way to I'm split apart. I'm someone else. I'm disconnected from my body. So this is a great chart that I like to use when I'm giving that psychoeducation to clients. And just like most and all mental health disorders, dissociation is also on a spectrum. And everyone experiences it slightly differently depending on what's going on in the severity. So on the left-hand side, we've got the more integrated end of the scale. And then on the right-hand side, we've got the more fragmented side of the scale. So on the more integrated, these are things that I'm sure many of us can relate to. So we've got that highway hypnosis. Basically, we're just in a trance while we're driving to work and we're like, oh, I don't remember getting off the freeway. How did I get here? Right? Or daydreaming, something all of us do when we're in a boring meeting. Hopefully you don't do it during today's training at all. And then next step is kind of during peak performance, or when you're really highly concentrated on something. I know there's been times for me personally, I've been so concentrated on something, people are like, oh, while you were doing that, this, and this were happening. And I had no idea. I didn't realize, because I was just so focused in. And then the next step towards more fragmentation is this dissociative or amnesia states, or fugue states. And so this is maybe when there's like a single case trauma. So like, I know I've experienced this myself with car accidents, where I maybe don't have a full memory of what happened before, during, or after the accident. All my memories are kind of jumbled up, and some of the details are jumbled, or I may have thought something happened, but something else had happened. So this is also very common in some of our single case traumas. And then we've got post-traumatic stress disorder. So clients are going to have more of the jumbled memories, and maybe some of that depersonalization, derealization. We move up the scale more to complex trauma, even more fragmentation, more of those different types of dissociation. And then we've got dissociative disorders, or DDNOS. And along with that, some personality disorders can fit in with that. Borderline personality disorder, narcissistic, and schizoid, where we there's just more fragmentation, more kind of parts of self, more uncertainty about who they are, maybe their identity and memory. And then we've got even more on the fragmented side, we've got the DID. And then also on the bottom there, it says polyfragmented dissociative identity disorder. And basically that just means that, generally speaking, when people say DID, they talk about maybe having 3 or 4 alters, maybe a dozen, but with polyfragmented DID, there's what's the word I'm looking for? Basically, different schools of thought is it could mean up to dozens of different alters or hundreds of different alters. So people kind of think 2 different things, but it just means there's more maybe than just a few. All right. And then really important, whether you have client who has DDNOS or has some dissociation going on, or someone who is DID, so important to recognize maybe some of the dissociative symptoms that you might see in session. So the first one is sudden shifts in experiences. So the client might be open and talking to you, then all of a sudden, maybe they just kind of shut down, or all of a sudden they just feel more distant from you. So those sudden shifts in experiences, becoming overwhelmed. And it's not just kind of the general client going outside of their window of tolerance overwhelmed. It's like you're just maybe talking about their trauma in a very soft way. Then all of a sudden, they are completely overwhelmed and they are not able to handle what you're talking about and what you're expecting from them in session. Unable to maintain dual awareness. So they're not able to talk about their trauma or their experiences or things that have happened in the week while maintaining their awareness in session with you. Then presence of childlike or self states. I have a client who will be talking, then all of a sudden I know there's a childlike state because she does certain hand gestures. She kind of does this little got your nose kind of thing with her hands, or else she will kind of start putting her hands close to her mouth. She'll stop making eye contact. Her voice might change a little bit. So we've got more childlike states going on right there. Sudden shifts in affect. I mean, kind of like what I said, she stops making eye contact, just kind of looks down. Or I had a client who we'd be talking and all of a sudden she would squint. And I kind of knew, okay, like there's a part maybe going on, or there's an alter that, and I knew this about her. There was an alter of hers that needed glasses. So every time she would kind of squint, I'd be like, do you need to put your glasses on? She'd go and put her glasses on. They may become unresponsive. So you might be talking to them and things are going along, then all of a sudden they just kind of stare off. You get just kind of this blank stare and they're clearly not with you. Or I even had a client kind of fall asleep while we were talking. Just all of a sudden he kind of leaned his head back and he was asleep for just a few seconds, didn't last long. But he dissociated enough that he fell asleep. I also had a client who had cataplexy, and cataplexy is very similar to narcolepsy. It's kind of like a step sibling to narcolepsy. And cataplexy is basically the client dissociates when they start to feel very strong emotions. And so with her, I knew if she kind of just started to slump over, oh, she's not with me. She's not with me anymore. She's losing some of her nervous system's kind of losing some of its functioning, and it's collapsing in on itself. They're unable to follow instructions, like simple instructions. They're just not with you. They're not understanding. They're not following what you're asking of them. Sudden headaches. That's a very common one. And then unable to maintain co-consciousness between self states. So they're not, basically, this is our DID clients. They're not able to maintain themselves. We've got different ego states or alters coming into session with us.
All right. I'm going to talk about the actual diagnostic criteria of DID. I'm the assessment person, love diagnostic criteria. So the first criterion of DID is kind of what it's known for, disruption of identity, characterized by 2 or more distinct personality states. So there's overall this discontinuity. We might see related changes in either emotion, consciousness, sensory motor function, cognition. And these changes in discontinuity are observed by others or reported by the individual. So I feel like that's a really important part to highlight, is that it might not be super observable. And nowhere in the criteria does it say it has to be really obvious to others. And this was something really fascinating to talk about with Triona when we did some consultation, was that a lot of people with DID tend to hide it and are pretty good at hiding it. So just because it's not super obvious doesn't mean it's not there. The next criterion is memory gaps, or just basically inconsistencies with just ordinary forgetting. We all forget stuff. This could be everyday events. It could be stuff about the person, and it could be traumatic events. It could be one of them. It could be all of them. So the implication here is that they might or might not remember the traumatic event. So we don't necessarily have to have amnesia around our trauma either. So I thought that was an interesting part to highlight. And then we have our kind of typical CDE that we put attached to all our diagnoses. It's significant distress or impairment, not part of a broadly accepted cultural or religious practice. And this will be important. I'm going to talk a little bit later about what this looks like globally and some of the cultural differences in DID. And then it's not attributable to things like substance use or medical conditions. Triona's going to talk to us about important vocab.
All right. We did have someone ask about like the basically stats of DID and how often the percentage.
Yeah, I'm going to talk about that later because it's actually super fascinating. Yeah,
okay,
there's a whole section on like prevalence. So
wonderful. Okay, great, awesome. All right, so we do have different terminology that we use when we talk about and talk to our DID clients. And so we've got alters. And so alters are basically those dissociative self states that they are recurring, and they take executive control of the client's body as well as their mental functioning. And so these alters, and I wrote down several of the different kinds, they can be protective, they can be persecutors. So they may persecute the self or the system. They can hold on to memories. They can be gatekeepers. They can be introjectors. They can be helpers. So there's lots of different ways alters show up, and lots of different roles that these alters will play depending on the client, depending on their coping, depending on their trauma and their experiences. And then we've got host or core identity. And so this is basically how the self existed before their alters. And we often talk about it's kind of how the client was born, how the child was born before these alters came to be, because alters can start at a very young age. But what was the client? Who was the client before these alters began to show up, began to be needed, basically. And then we've got apparently normal parts, or ANPs. And these two terms, the next two terms, are specifically with structural dissociation theory. And so apparently normal parts, I mean, it's just like how it sounds. And we're going to talk a bit more about these, but these parts of them and these alters appear normal. They're the ones who most people are going to see, and who we're maybe going to see when we first meet a client. And then we've got those emotional parts. And those emotional parts hold on to the memories. They're the ones who store all the emotions. They're the ones who get triggered and bring up all the emotions. And so these are more of those persecutor parts, the interjectors or the memory holders, alters. And then we've got system. And so basically the system is just the collection of alters in one body. So you can use system. I have a client who calls it her collective, inner world. There's lots of different ways that you can term that. And then switch. I also call this fronting. And so basically that just means when one alter takes control of the system or is given control by the system. And so it's switching to another part, or it's one part is kind of fronting and the system's back here. All right. So structural dissociation model assumes that no one is born as a fully integrated self. It's that we're born with a loose collection of these ego states that handle our different needs. So when we're first born, they handle the need of attachment, of being fed, of, I'm trying to think of other things that babies need right now, right? Of just those basic needs that we need when we're born. And then over time, the idea is that we naturally integrate as our needs are being met. However, trauma can disrupt this development. If attachment isn't there, if basic needs are not being met, that integration is not going to quite happen. And so in DID, this happens before 6 to 9 years old. That's 6 to 9 years old is generally when that integration begins to happen. So with DID, we know trauma has happened at a very young age. And so, what was I have another note here. I'm trying to remember what I was going to say. Yeah, I guess that's it. Sorry. All right. And so, there's 3 different kind of types of structural dissociation. So the first one is primary. And so that's basically when a person has one of those apparently normal parts that's in charge. It's in charge most of the time. And then there may be certain triggers that bring an emotional part forward. So this is going to be some of our less complex trauma clients. And so we've got this normal part that takes on the day, that handles everything, that's in charge most of the time. But then a trigger happens and suddenly we've got an emotional part. And then secondary basically is when there's one of those apparently normal parts that's in charge, but then there's lots of different emotional parts, each maybe with its own trauma response, which means there's more of that trauma from childhood. So they're being triggered maybe by, oh gosh, I'm trying to think, maybe triggered by certain people in their life, being told certain things, certain circumstances, noises, or touch, whatever it might be. So they have more of those emotional parts. And then tertiary is when the person has lots of apparent normal parts, and then there are multiple emotional parts. And those, I should say, maybe I should have just read this, but the person has many of those apparent normal parts that can overpower each other. And then there's multiple emotional parts. So those apparent normal parts, there's lots of them. So they can maybe fight for who's going to be in charge and who's going to show up during, this social event or during work or whatever it might be. So there's more fragmentation because there's kind of parts competing to front or to switch. All right, so this is where we're going to talk more about those ANPs and EPs. So apparently normal parts, they are present oriented, and they just handle the day-to-day functioning. So they're in charge of social interactions, taking care of others, work, play, learning, taking care of clients' physical needs. So they're, like I said, they're the ones who we're probably going to see a lot of, and who all of the clients, maybe loved ones, see. Client with DID, like Laura was saying, people may not know, people may not recognize. They're really good at hiding it because they have a lot of these apparent normal parts. I have a client who no one in her family knows that she has DID because she has so many amazing ANPs and helper parts that get her through her day. There may be weird little things her family kind of is like, well, that's just weird, but that's just mom, right? But she just has so many of these parts. And these ANPs, they need to appear that they are high functioning, and they avoid those emotional parts at all costs. They limit those emotional triggers as much as possible, and they don't want to talk about any of their emotional parts. They don't want to be triggered to have one of those emotional parts come out because they want to stay in control. They want to continue to appear normal. And these emotional parts, they're the ones who contain the trauma. They're the ones who have the memories, the perceptions, the beliefs, the responses, the body sensations. So these parts become present with any of those trauma triggers. And these parts, and I forgot to say this before when we talked about alters, but these emotional parts or these emotional alters, they could be adults, they could be kids, they could be any age, they don't necessarily have to be human, they can be animals. And so these emotional parts and alters are going to show up in lots of different ways for clients. They have heightened emotions, they have flashbacks, they may not be aware of the present. That's why a lot of times the client is not having that dual awareness because they're back in their trauma. They're reactive, they're compulsive. Those emotional parts are going to go and sabotage or do things that are going to maybe hurt the system or hurt the core self. They're the ones who are going to maybe do some self-harming. They're the ones who are going to I know of one client who he goes in and meets up with people, and that's one of his emotional parts, meeting one of their needs. And so, but these emotional parts, as destructive as they can be, and as much as their apparent normal parts want to avoid them, those emotional parts are the survivors. They're the parts of self that took on the trauma, that held the trauma, and survived the trauma.
We got a couple questions in the chat as you were talking. So first one I can answer, which was, what if the DID presentation is not troubling or distressing to the person? What would that be? And the answer is kind of, it depends on what's going on with the person.
Yeah.
So it could be, maybe they've gone through therapy and have kind of like worked through some distress pieces. They could have like other specified dissociative disorder where it's not quite DID. There's some of these other traits. It could be something else. So we'll talk more about that in like the differential diagnosis piece. But yeah.
Mm-hmm.
And then a question for you specifically, Triona, because I wouldn't know the answer to this, is in the IFS model, is an ANP the same as a manager?
Yes, I would say it is. Absolutely. Yep. And we'll talk a little bit more about IFS later.
And then we're getting some more questions in here about spontaneous self-hypnosis questioning. Yeah, so we're going to talk about some other theories of the DID right now. And then, was Billy Milligan a tertiary type? I don't know if I know who Billy Milligan is.
I don't either. I'm so sorry.
Okay, sorry, maybe. And then how to differentiate from DID from malingered. We're going to talk about that right now. And
Okay.
thanks for submitting all your questions. So yeah, I'm going to talk about some models that are different than the structural dissociation model, which are more of that suggestion, self-hypnosis, socio-cognitive, you know, whatever, all these kind of other different explanations of where this presentation could come from. And so they kind of tend to fall in two categories. Iatrogenic is like, this was built in therapy, like mental health providers are giving, you know, like, oh, am I talking to someone else right now? You know, or whatever. I don't know how you would develop it, but that's a category. And the other category is socio-cognitive. So it's caused by some type of environmental influence, whether that be like friends, family, social media, media. And essentially, what the research says about this is there's kind of a few different explanations for these models. One is a concept called fantasy proneness. So it's this suggestion that like they're a certain kind of person that might be more prone to like fantasy and daydreaming and having really vivid, intense, creative imaginations. And this type of person can struggle with like differentiating fantasy from reality. They have a lot of out of body experiences. And this is the type of person where DID then would develop from like a suggestion place. So fantasizers have been kind of explored in research by Wilson and Barber. This is from like the 90s. And some traits include things like they're a good hypnosis subject, you know, if they're suggestible. Maybe they have a lot of imaginary friends as a kid, or they fantasize a lot as a kid, or they have an actual fantasy identity, like a little kid has like a superhero self or something like that. They have a lot of vivid sensory experiences and relive past experiences intensely. They might feel like they're kind of like intuitive. That's like a hot word these days. Like, I'm such an intuitive person and I feel and sense these things. And maybe they have psychic abilities or are really aligned with some of these spiritual healing or faith healing things. They could even have hallucinations. They could believe some more delusional things like alien abductions, right? Like stuff like that. Well, I don't know if there's alien abductions for real, but in general, we don't want to just dismiss that. But so that's the kind of person that says like, oh, this is where DID can develop because you have this trait. But what is interesting about the research is that DID patients actually have very low fantasy proneness. So they are the type of person that is not going to have that difficulty distinguishing reality from fantasy. They have actually pretty excellent reality testing abilities. And people have done some research where like fantasy prone persons, I said it's not always pathological either. Like they describe it sometimes as like, oh, it could be almost psychotic, but sometimes it's just like, you're really creative. So that kind of gets rid of that theory a little bit, where it's like not super supported. And they've done a lot of studies where they have people that try to like simulate DID versus more like clinically established patients and try to see like how they compare in some of these traits and things like that. We'll talk about that more in the assessment piece. And these studies showed that in general, people with DID are not more fantasy prone than the general population. And then even like imitators couldn't mimic that on some of these instruments. So fantasy proneness can come from things like maybe it's like a coping mechanism for abuse or isolation and loneliness or boredom. So it has some similar like origins of like maybe this was an adaptive coping, the same way that fragmentation is an adaptive coping in some ways, for like that early childhood trauma, but it's not the same. It's definitely distinct. Then malingering. Yeah, well, let's talk about that. So people malinger things all the time, not just DID, like all mental health disorders, all health disorders in general, like illnesses. And so research shows that people don't malinger DID any more than they malinger other things. So it's not like if a patient showing up with this, it's like, oh, they must be malingering because that happens so often with this disorder. Not really. And I'm going to talk a little bit more about how to distinguish malingering, but then to get to the other piece, the iatrogenic or environmental influence piece, this is usually not developed in therapy, and they had a few different ways where they studied that. So one way is they kind of compare, were there established dissociative symptoms before they even entered treatment at all, and they were able to verify that yes, they had some of these traits and behaviors before they ever interacted with a mental health provider. Most people with DID do actually get better in therapy. They found that in one study, only about like 1% got worse in therapy, and it wasn't the therapy itself necessarily. It was because they had some re-victimization or other significant stressor that happened in their life during that time, and that led to more kind of like a deterioration of symptoms. So maybe the iatrogenesis myth comes from if potentially there could be like a bad fit, like maybe it's an inappropriate intervention to use with DID, and then you could exacerbate or, highlight even more symptoms, but it's not inventing symptoms that weren't there before. And then there's always, in terms of other environmental influence, there's cultural influence in terms of like potentially how it could present, just like with any other psychiatric disorder. We always have, in the DSM, that section about like cultural consideration, so I'm going to talk about in a little bit kind of like DID around the world and like different populations, but overall, there is cultural influence on maybe like how it presents or how people understand it, but it's not like it generates out of nowhere based on an environment. Even social media, which I know is a thing now, and we'll talk more about that too. Then with the malingering, here are some ways to kind of tell potentially, or some like red flags for malingering or trying to fake DID if that is happening. For DID specifically, the research shows that sometimes there's an inconsistency about their reported history with someone's like medical history. Like maybe there's like documentation of some things and what they're reporting doesn't match that documentation. They have a lack of post-traumatic stress symptoms along with the DID. They might have more like dramatic or bizarre rare symptoms. And general indicators of malingering overall that don't uniquely apply to DID could be things like exaggeration, persistent lying, lack of prior dissociative symptoms at all before they were kind of in this setting. Looking at the motivation of your patient, of like, do they feel this need to assume a sick role, and have they shown that in other ways historically? Are there certain motivations, whether that's from like a legal or medical perspective? There's certain like relational qualities of like parent-child relationships, and they talked about demanding attitudes toward caregivers. Like, are they trying to like get something from the people in their life? They have a lack of overall previous psychiatric history, which, as we know, with DID, they have so many comorbid disorders that it's super unlikely that we wouldn't have seen, anything prior to this. The symptoms are not consistent. Maybe there's a lack of observed symptoms. I said that in and of itself isn't a rule out, but is another kind of piece to the puzzle. And if they don't really want to participate in any kind of like formal evaluation of it or more exploration or get collateral sources or documentation. If they're pretty resistant to that, that could also suggest they're malingering. So as I said, it doesn't happen more often with DID than with other disorders. It does happen, so it's important just to always kind of keep our mind on that and like think about what feels inconsistent and think about motivation and potential like reinforcers. There also is a type of presentation that's called more like imitative DID, which this is where an individual might truly believe they have DID, so they're not purposefully malingering. They might have like some of these traits, but then feel really aligned with this diagnosis, or there's some evidence that like exposure to things like social media and information can actually create these symptoms. They did this research with tics, where people were having like more tic disorder behaviors, not on purpose, but just like kind of the exposure to them led to more of that. So sometimes that can happen, is that it's not usually, and our diagnostic instruments are pretty good at distinguishing between the two. So as I said, it's not impossible, but it's going to be pretty uncommon to have it happen this way. Okay, we're going to shift to talking about barriers to accurate diagnosis. I'm just going to double check we don't have any. Oh, we might have some outstanding questions. Okay, we're going to shift to another section. So yeah, obviously people have a lot of exposure to this in the media. And this contributes to, you know, common like misconceptions and inaccuracies and things like that, you know. Sorry, this is a spoiler for Fight Club. You know, it's a 30-year-old movie. You had time to see it, but yeah, he has DID. And so the main take home with this is that it doesn't usually look like this, essentially. So I love United States of Terror. It is a great show. I highly recommend it, but it created a lot of like problematic stereotypes with DID for sure, in terms of like how extreme the shifts are, in terms of like how much, you know, alters or people could potentially communicate with each other, or they see them outside of themselves. Not that that's like impossible, but generally doesn't happen. And that they're all like, there's a secretly murdering alter, which we'll talk about, which usually doesn't happen. So the media definitely contributes to a lot of the misunderstandings and a lot of the like misdiagnosis pieces. So I want to go through some common misconceptions people might have with DID, which we kind of addressed this with the malingering, but like people are making it. It definitely is empirically validated. There is a lot of evidence from like neuroimaging, from analysis of like hormones and blood pressure, and like a thing that a person couldn't really change that distinguishes the different parts, you know, the ANPs and the EPs, the different alters. We see that actually on a neurobiological level, which is pretty interesting. But we can't throw everyone in a scan, but you know. Prevalence rates. Someone had a question about this earlier, and I thought this was so fascinating because I think we always hear like, oh my God, it's so rare, you'll never see it, you know. So the prevalence rate in the general population is about 1 to 1.5%, which doesn't sound like a lot, you know, but when you compare it to other disorders, like let's look at bulimia, for instance, that occurs in about 1.5% of females and 0.5% of males. OCD occurs in about 1.2% of the population. Borderline personality, I mean, I feel like as a DBT center, I see everyone is borderline, right? No, it's 1.4%. Schizophrenia, or kind of that spectrum of disorders, is less than 1%. So DID is more common than schizophrenia, could be more common than OCD, could be more common than BPD, more common than bulimia in some populations, right? But if we see these people, like if they have OCD, we're like, oh my God, no, that's so rare, you know? No, we never think about it that way. So I think the take-home message here is like, we aren't just like regular people on the street just meeting people, you know, we see a clinical population. So we are going to see some of these disorders. So it is rare in the sense that it's not, oh, people sent us information about Billy Milligan. Okay, I'm gonna look at it later. So yeah, it's an important differential, especially if your client has a trauma history or an early childhood trauma history in particular. So I definitely encourage, yeah. Percentages seem high for the general population. Yeah. That's what the NIH says they are. So, yeah.
And I'm just going to interject here if you don't mind, Laura.
Yeah.
It's crazy to think because a lot of our DID clients who do come in very fragmented, they often have, if they've gone into the hospital before, they often are told, oh, you're schizophrenic. You have some sort of delusional disorder. But like you said, Laura, the statistics say that actually DID is more prevalent than schizophrenia. So, and I just think people are more, at least I know when I worked at an inpatient hospital, doctors were way more prone and more comfortable with giving out a schizophrenia diagnosis. And actually, for a long time in my early career working with these psychiatrists, I was like, oh, DID is not a thing. Totally fell into this misconception because I don't know if it's the lack of understanding, the lack of comfort. It's just, it's very much believed that it's not a thing. By a lot of inpatient psychiatrists who I worked with. And so a lot of clients do get that diagnosis when that's really not what's going on entirely.
Yeah. Crazy. I know. Well, let's talk about another common misconception. So this we talked about a little bit too, but people with DID are unaware of their past trauma and altered states. So if they are aware of any of them, then they're faking it or whatever, or it's not real. Which is also not consistent with the actual diagnostic criteria, which, as we talked about, they could be reported experiences, not necessarily observed. Signs of alters and dissociation are often present, even if the person doesn't really understand what it means. And when I say signs of alters, sometimes this can look like maybe here, it could almost verge in the realm of like almost looking psychotic, where maybe you like hear certain voices or have these certain feelings that you don't feel like belong to you, or the other pieces of dissociation, kind of like losing time, feeling real disconnected. So again, it doesn't have to be super obvious. And then there's co-consciousness, which is what it means if like a person, someone's fronting, but someone in another part has awareness of what's going on too. And co-consciousness, and then this was something that I was talking about with Triona the other day too, is that like, it's not super common for someone to just like have co-consciousness without doing some therapy work or some work through it, right? Like, so sometimes it could feel like if the client's coming to you being like, here's all these people, this is what they do and here's what they are. It's like, okay, not impossible, but it's kind of rare to have super overt co-consciousness from the get-go, unless there's some work around that. Is that right, Triona? Yeah.
Real fast.
Yeah.
There's a question that was asked. It says, can DID resolve on its own over many years without significant therapy service or of some kind? For instance, PTSD can sometimes resolve slowly over a long period of time, but of course, appropriate therapy and level of care will be way better. I don't know what your thoughts are, Laura, but DID isn't necessarily something that is cured. And we'll talk more about that. But generally speaking, and kind of going back to what we were saying before, I think it depends on the amount of the client's DID, like are they in secondary or tertiary, but also how much it is influencing their day-to-day functioning in life.
Yeah.
Yeah.
And I think this will be so fun to talk about when you talk about treatment, but it's kind of a misconception that the be all end all goal for everyone is going to be full integration. Sometimes that's not where it ends up. And it's more about having, increased co-consciousness and awareness, less dissociation overall, having all the parts kind of aligned to the same goal and, working together. So a person might end treatment and we could consider that, a good treatment episode, and they still have these parts. Other pieces. This I thought was an interesting stat from the researchers, that only an estimated 5% of the DID population have really overt switches between alters where they look significantly and present significantly different. It could be more subtle, because they, as Trona was talking about before, like more voice changes, slight mannerism changes, but having this, as I said, United States of Terra, like different like outfit and everything. And that's not very common. And usually there is a function to this. DID develops as an adaptation to trauma. So obvious behavior could be dangerous to that person. So if a person is in a child, it usually is in an abusive situation, and they're using this as a way to kind of cope with that abuse, if they do have these super overt changes in their environment, it could signal to the abuser, like, yeah, something to attend to and something, so I think it makes sense why this might be hidden on purpose. It's like, it's our hidden coping skill. So from an adaptation functional behavior standpoint, it makes sense. There's another misconception I wanted to address, which is like alters always represent specific role types or archetypes. And we do kind of use some of this language of like, oh, there could be child parts or helper parts or perpetrator parts, but not everyone has to have all of these parts, and not everyone has to have parts that have these like distinct roles and functions either. So it's not super productive in treatment to like force an alter to like fit a specific role, or try to like make that known. And then there's not an evil alter that secretly kills people without the other alters knowing. Like in all of these movies, the character in Split, as I said, that's going to be more exaggerated and probably not super accurate. They could be any gender, age, sexuality, race. And as Triona mentioned before, they don't necessarily have to be human. And like when we were doing research on this, I found kind of this passage where for many kids, being a human is scary, right? Like a kid is the one that's kind of first experiencing these traumas and where this fragmentation is happening. So it would make sense where the alters are something super relevant to a child, like a dinosaur or, a dog or whatever. So maybe this like more kind of loving creature or non-human creature can just feel safer to be in their environment. But it's not a conscious choice. It's not due to any specific planning or whatever. It does happen but it happens through a child's mind, through their understanding of the world, and their heavily dissociated state. So anything as an alter is pretty fair game, because I said this is a very young child's perspective usually. someone asked the question,
Yeah,
can
I was
alt,
just oh,
yeah,
yeah, I was
can
just gonna
alters
yeah, I was just gonna
die?
interject. Yeah,
Yeah,
so someone asked how does the movie Split do with DID? I personally haven't seen it with certain movies like that kind of villainize individuals with DID. I'm like, I don't want to watch it. I don't even want to see it. So I haven't seen it. I don't know if you have, Laura.
I have. I've seen all the three, The Unbreakable, Split, Glass. They're
Okay.
great movies, but yeah, it's not
Not
I
a
don't think a helpful
right,
depiction.
not a fair representation. Yeah, fair.
Yeah.
And then someone asked if alters can die,
Hmm.
and which I've absolutely seen it happen. And personally, I don't believe alters can die. Usually when clients say like they're not around anymore, or they died, or they went away and the other parts had a funeral, or alters had a funeral for them, or whatever it might be, it usually just means that that alter maybe is no longer needed, or it's become integrated. It's kind of
Yeah, that's what I was gonna say is like all of these pieces are parts of the person. So there's no way for them to die. They're always in there. But I said they might have been absorbed into maybe like the role of another alter, or just gone inaccessible or more like unconscious. Because I've also seen that too, where a person with DID lost a part, and it was actually a very like they were having an intense grief reaction and like had to process through that, and it was yeah, like sometimes it's really difficult for that system to experience that loss, but it is a genuine experience of loss. But they said it's all within the same, brain body, so it doesn't necessarily disappear, but it just might not be accessible. Yeah, go dormant, someone said in the chat. Yeah, kind of go hidden. The idea is a Western phenomenon. It's made up. We have all these movies and then it just happens here. It's not true. It's worldwide. Prevalence rates are actually pretty consistent worldwide in terms of like percentages of a population. Yeah, I realize those two statements could seem contradictory. So the first statement is prevalence rates are consistent in terms of like percentages, but in terms of like actual frequency, it might be more common in developing countries, which would make sense if we think about an early childhood trauma model, where like if you grow up in a place or are born in a place that is highly prone to chronic traumatic stress experiences, like you're in a war zone or it could happen more often in those settings. However, culture does influence presentation, and so there's a lot of evidence that suggests people with DID in non-Western cultures have more of a conversion disorder like presentation, kind of what Jonah was describing a little bit earlier with the client that has cataplexy. Like you see more of that piece, or you see cultures who kind of have this experience of I'll kind of shift to it because I think maybe I talk about it later, but I'll talk about a little bit later, but there's these like kind of culture bound dissociative disorders that exist, and like almost like possession models and things like that. So like it could kind of look like those. So it does exist all around the world, and even the measures that we're going to talk about are validated in lots of countries. So it's kind of fun. It's not uniquely Western. They've done a lot of studies where they've kind of explored presentations of trauma in areas where like DID is not well known or studied or in clinical practice, and kind of can still identify some of these people. So yeah, it's really interesting. And then I forgot to mention when it comes to like the types of alters and like how there's never like an evil one that kills people, that might have come from the concept of an introject. And I think Triona mentioned like offhand briefly said that. So an introject is an alter that maybe like represents someone in the person's life, like their abuser, or like And so they take on some of those traits of like, if they're receiving a lot of, you know, verbal or physical abuse, or like stigmatizing beliefs and identities and harmful stereotypes, like all of that could be represented and alter and interject. So yeah, they could be harmful to the person sometimes. Yeah. Let's talk about social media. Yeah, it's come up a lot, I think, that because it's kind of popular on TikTok and YouTube and other social media channels, that many people are now coming to us and being like, do I have this? Or I feel like this resonates with me. And overall, I think while we might have a lot of anecdotal experience with that, the research is actually pretty limited to kind of like prove that connection. So we'll kind of talk about like what the research does show when it comes to like social media and DID. One is that they've done a lot of more like qualitative studies of like what actually is this content out there and what are the messages in the community. And it kind of essentially fell in like 3 categories. So one was that it just describes a person's experience. Like, here's the structure of the system and the alters and kind of what it's like. And the pieces where they kind of talk through, you know, who's fronting at the time or whatever like that. There's all these kind of signals and language there. Then they talk about boundaries. And what I mean that is there's like messages in that community that say, do not interact if, do not interact if you don't believe in DID, do not interact if you're going to make negative comments, right? So like they try to make it a supportive, kind of protective community. And usually the messaging in there is very like positive, validating, accepting, kind of like trying to have a safe place in the community, but also making sure that the people who do participate in the communities are genuine, essentially. And they always tend to comment on whether or not they've been officially diagnosed or not by providers as well. And then there's intersecting identities, which there's a question in the chat of like, is there a higher prevalence of DID among individuals with gender dysphoria or transgender? I'm not sure about higher prevalence, but in the social media analysis, the 2 most common intersecting identities with DID were the LGBTQ kind of spectrum and neurodivergence. So those 3 seem really attached a lot. And it could make sense for if you look at trans or gender dysphoric individuals from, like I said, a chronic trauma standpoint of like having that as their identity and just navigating the world, and especially the world right now, right? So makes sense in some ways. But there's no evidence there's no like specific research connection in terms of like prevalence rates that I'm aware of in that population. So one interesting thing that they highlighted in the social media research is, while there's all this kind of like safe space talk, collective identification, resonation of experience, there's actually very little discussion about treatment. Like no one talks about what do we do about it, or like, do we do anything, you know? Maybe they're not distressed about it, as someone had mentioned before. So that, yeah, that's kind of an interesting thing. It's like all about kind of acceptance of it, less so how do we change this? So, and this particularly affects adolescents. So some research on just like the rise of self-diagnosis and social media in general aligns with some parts of the normal identity development process in adolescence. And so there are some theories that suggest like COVID-19 during this highly critical developmental period might have disrupted that identity development, and then they kind of turn towards other places where they could feel a sense of belonging. And they in general might be just more prone to things on social media just because they have more of a lack of access to resources or control in their lives. Like, it's not like they could just go to a mental health provider if they wanted to without involving parents, you know, who could be their abusers, right? Like, if this is early childhood trauma. So it's really important to kind of consider, if you are noticing a lot of teens present with a lot of emphasis on these traits and feeling like really strongly attached to this diagnosis, in some ways that makes sense. If you feel like it's not genuine, it's still not helpful to just dismiss them or explain it off or brush it off as like, oh, you're just trying to find, you know, whatever. You're just trying to belong somewhere or find an identity. It is just important to validate that experience of like isolation, identity disruption, searching and exploring different communities, and you can gain more of a stronger relationship in treatment. And as I said, Triana, I think, is going to talk more about that when we talk about treatment. But so it does make sense why we might be seeing an increase of this in teens. I also think it's interesting. There's some studies that suggest that parent trauma and dissociation, or like intergenerational trauma, can influence a child's DID as well. So it's unclear whether that's like, is that heritability versus like just said that intergenerational trauma experience, but it could be more influence in the environment as well. And so what we try to do with this is think about how we can help parents and how we can help our teens in evaluating content on social media, which includes things like supporting social media literacy, you know, asking questions like, what are this content creators' qualifications? Are they selling you something? Is this information consistent with information found elsewhere? Are they talking about their own personal experience versus making generalizations to a disorder overall? Are people maybe really motivated to be part of this community in a way that's like avoiding treatment or avoiding confronting some of these trauma experiences and the reality of their history, right? And so I think also it's what we could do as providers is either put content out there, which someone linked in the chat, a provider who talks about their DID, which is awesome. And then if we find good quality content out there that is research aligned and does come from an appropriate source, we can elevate that more and get that more visible, right? Because essentially, like, people, you know, the community are in these spaces. We can't just be like, don't look at TikTok, you know. What we can do is try to improve or elevate the quality information that's out there and help make that information more accessible to others. So the culture-bound dissociation that I was talking about before, as I said, many of these disorders have kind of dissociative or possession-bound experiences, where like a possession trance is like, there's this new identity, maybe a spirit or God or something is in you, and maybe they're less likely to seek treatment about this because it might be viewed as a good thing in the community. Like, I don't know. So it is interesting to kind of consider, like, we have all these different names for these different culture-bound dissociative experiences, but are they actually maybe like aligned in some way with a broader diagnosis, just kind of like present slightly differently? And when it comes to BIPOC individuals in more like Western countries, like the United States, there's pretty limited research, unfortunately. But if you think about the trauma model, chronic exposure to trauma would increase the risk of PTSD, dissociative symptoms in general. So it would make sense for it to appear more often in more vulnerable populations. However, these individuals are also more likely to be misdiagnosed. And so one study kind of explored that African American individuals with trauma were more likely misdiagnosed as schizophrenic or had conduct disorders as a kid, or there was more focus on the way that they try to deal with these intense emotions like substance abuse and missing other important comorbidities. However, the presentation is going to be pretty similar within like a demographic population of a nation. Does possession include traditional evil spirit presentation? Yes, so there are some possession disorders that like there's one I think I mentioned before called amok, which is a disorder where a person suddenly and manically murders a bunch of people and then maybe kills themselves. Like, so sometimes they include violent behavior, but it's pretty rare. And then evil spirit presentation, yeah, I said it, whatever, depending on the cultural norms of that country. And then these are a few common comorbidities. So like, so when you do have a person that has DID or dissociation and trauma, we want to explore these as well. And some of them are more obvious than others, I think. Like, yes, of course, PTSD, like for sure, reactive attachment with early childhood trauma, where some I feel like are like, okay, less, like borderline personality. There's a ton of overlap in the symptoms in terms of things like identity, instability, dissociative states, and but research has kind of like distinguished between those populations using different testing instruments that we'll get to, so that they are different, but there is a lot of overlap between the two. And then when the populations with DID start experiencing less distress, like when they enter treatment and some of their distress is lowered, their similarity to a BPD person is like drastically different, right? Like in terms of the emotional dysregulation and the suicidal and self-harm behavior, right? It's like just less common even. I was kind of surprised at the feeding and eating disorders piece. And so the connection there that I was looking for throughout in research, they suggest that a lot of disordered eating can happen in almost a dissociative way. Like if you think about a binge eating episode, like a lot of people talk about feeling like really out of it or not in control, things like that. There's some research that suggests that patients with eating disorders have pretty poor insight into like how their body is connected to themselves, and there's a lot of separation of like and hate towards themselves or different parts of themselves, and so there's also evidence that like people with things like anorexia or bulimia might have some of these like ANPs and EPs as well, like maybe like less fragmented but still kind of present. So it's just really, yeah, really interesting, that connection. Bipolar, yeah. Honestly, we could almost throw like anything on here because I feel like trauma is so like, so yeah, bipolar we could probably throw on there too. Just, yeah.
There was a question, Laura, asking if there's a minimum age of diagnosis, and
yeah,
I wasn't sure.
So the research with that looked at DID potentially in children suggested that while there is early childhood trauma, and we might see some evidence of this fragmentation starting around that age 6 to age 9, it's pretty hard to diagnose before adolescence, when we see more of that identity developmental process and more pronounced parts. So it would be not impossible, but pretty unusual to diagnose prior to teen years, just because it hasn't kind of fully manifested yet.
Yeah, I don't think the DSM specifically says like with BPD, it can't be under the age of 18, but I don't believe DID has anything like that.
Yeah, there's no specific age bound requirement, but the research just kind of shows where we could find it, and what our instruments are validated for too is another piece. So maybe if we had better validated instruments for younger populations, we could diagnose it better. So let's see. Yeah, lots of good discussion in the chat. Okay, assessment of DID and dissociation. I'm gonna run through some of this a little quickly because I want to make sure we have a decent amount of time to talk about the treatment side. But let's talk about what we do for assessment. So the first instrument that I want to highlight is the Multidimensional Inventory of Dissociation, or the MID. This is a very fantastic instrument. I love it so much. So we're going to talk about it a lot. Number one, it's free. Link to the website there. Go get it. I think all you have to do is submit a request. They have like a request form you submit to the authors and just like prove that you're a credentialed provider, but they give it to you for free, as well as the scoring. It's all like this fancy Excel spreadsheet. So, and I'll show you the kind of output you're going to get, but it is a self-report measure. It's 218 items for the full version. There is a short version that's 60 items that also gives some helpful scales. So if you're like, I don't want to do 218, there's a 60 item version that I think is more commonly used in like treatment settings. There's an adolescent version. There's norm comparison groups, which I'll go into, which is so exciting. There's validity scales for all those malingering people, and it has cross-cultural validity. So it's been validated in like many different languages around the world. So super fun. So what you're going to do is when you put your person's responses in the scoring sheet, you're going to get a few different outputs. One is like a very broad kind of like face summary sheet that I'll kind of break down for you guys. And I said there's a manual for this. There's also a cheat sheet for this that's shorter than the manual. So it's very accessible. But they do have like trainings on their website you could do as well if you wanted formal training. But I said it's very accessible, lots of resources to support it. But this is an example output of a de-identified patient. First, it's going to give you some diagnostic overall impressions. It will talk about, what level of like post-traumatic stress exists in this patient, what level of pathological dissociation exists, whether there's somatic symptoms, and whether there's borderline personality traits. Then it's going to go through and give you some validity scales, which on the top left corner here. So for this person, for example, they were scored pretty high on the minimization, but not super high, like 2 out of those items, but 70 out of 100 scale, and like maybe mid on the emotional suffering piece, which is a scale that kind of assesses, from this person's perception, do they feel like they suffer emotionally more than other people, essentially. But they also have scales for attention-seeking behavior, fictitious behavior, manipulativeness, super rare symptoms that even in like a dissociative population wouldn't typically be endorsed. So that is super helpful to kind of like parse apart those pieces. They give like an overall mid score. They give a DID scale score, amnesia score, dissociative symptoms. There's a couple other things in here I want to highlight. They do psychotic screening in here as well. So they have scales where there might be some psychotic-like symptoms that people with dissociation report, and there's distinct psychotic symptoms that people with dissociation don't really report. So they have kind of a way to parse that apart. They also kind of have these different sections for the types of alters that might exist. Like it's very common to have child parts or potential helper parts or persecutor parts. So like they go through that. They go through different levels of dissociation and trauma. So they have general PTSD symptoms, some partial dissociation, and some like full dissociation. So they can kind of break it up in that way as well. And then those first strength symptoms, as I said, are more of the like psychotic symptom pieces. So yeah, you get a lot in here. I'm going to go through some of the tables too, because it's cool. So you get graphs of like where your patient compares to a non-dissociative sample, a DID sample, an OSDD or formerly DD and OS sample, and a classic PTSD sample. You also get graphs comparing to DID and BPD populations. So it's just really cool, and I highly recommend it. For the short version, you don't get as like in-depth analysis as this, but you do get 12 subscales, and some of the subscales are DID specific, some are more depersonalization, derealization, some are post-traumatic stress, some are conversion disorder. So there is a way to kind of break it up with the short version as well, but it's not going to be as in-depth as this. So yeah, go use the MID. It's so cool. Other instruments we use are the structural clinical interview for the DSM-5, the good old SCID, and there's a specific one for dissociation, and it's been validated to kind of distinguish DID populations in adolescents and adults. It's updated for the most recent version of DSM. So it can be really helpful. I think an interview has a lot of advantages to self-report in some ways, because you can ask more specific questions about what the client is reporting, and maybe like sometimes with self-reports there could be a lot of like misinterpretation or just like different interpretation of the questions. So you can really get at like, is this an accurate symptom that they're reporting, or is this actually a different experience? Then there's the dissociative experiences scale, the DES2. It's been updated. This is a good screening tool. I said it's not going to give really subscales. It's just going to indicate like how intense are a person's dissociative experiences. So a research suggested clinical threshold for potential DID patients is about 30, but that also would include, other specified dissociative disorder. It might include psychosis. It might include severe PTSD. So it's not specific enough to really separate out DID from other types of trauma and dissociation, but it is really useful to, one, just kind of like have more of a conversation with your client about their experiences, and to determine if like further assessment is needed. So I said I wouldn't use this. Yeah, someone says it's a decent screening for ADHD, the MID maybe, or one of these. Yeah, I'm going to talk, or the DES. Oh, okay, good. Awesome. Yeah, neurodivergence is an important rule out that we'll talk about. Yeah, so good screening tool, not necessarily diagnostic tool, but it is, as I said, it's freely accessible and not much training required to use it. So it has its advantages there. And there's an adolescent version. Then I like to kind of walk through what else might you include in your testing battery, or what else are we going to use to evaluate for potential. There is a child version. Yes, it would be a different version, but there is a child version, and I think it's much shorter. It's like 9 questions or something. Anyway, trauma assessment, we have some of these instruments, the kind of classic CAPS-5, for like that initial diagnosis question of like, does PTSD a good fit? And then using something like the PCL-5 for like continued monitoring the symptoms. That's very well researched and very well validated. Thanks VA for doing that for us. So that's a great one to use. The PCL-5 is freely accessible. The CAPS-5 I don't think is. There's the traumatic stress inventory, which is a self-report scale for adults about different traumatic type presentations and associated symptoms. I like that instrument a lot because it does have validity scales as well. For more of our child and teens, we have the UCLA PTSD assessments, and that would include both a parent and child report. and we have the trauma symptom checklist for children. There is a young child version for that under 8 population, but the parent measure for that goes from 8 to 16. Also not a freely accessible one, but a really useful one that has some validity scales and some different subscales for types of trauma experiences. So you definitely want to assess for trauma for someone who has DID. Then we have our personality assessments. And so DID, even though it was formerly called multiple personality disorder, it's not a disorder of personality. Like, it's a disorder of trauma and dissociation. However, there have been personality instruments that have been used to create profiles of DID patients and how they differ from personality disorder patients. And so it's really cool. Like, so on the MMPI, for instance, this study was actually, I think, done on the 2, not necessarily the 3, but the people with DID had more like consistency. So some of those validity indices for the inconsistency scale would come up from malingered profiles, whereas DID had consistency. And then DID had an association with scale 8, which is formally like the kind of schizophrenic scale, which we say it's different than schizophrenia, but anyway, scale 8. And that they generally have a higher F level, and F is like distress level. And so sometimes a higher F on that instrument is supposed to be like, oh, they're over-reporting or exaggerating symptoms, but it's important to remember that this is pretty severe pathology. So just because that one is high, it doesn't mean the profile is invalid. It's actually probably going to be high. But you have to look at some of the other validity scales as well to see, like, oh, is it consistent? Are they, reporting super rare thing, So they also showed that people with DID on the Milan scales had high profiles on avoidant, self-defeating, borderline, and passive-aggressive traits, as well as anxiety, depression, somatic substance use traits. And these profiles changed as they went through treatment and became more integrated. So these are great instruments to use, and I linked, there's adolescent versions and like child versions of the Milan scales. The MPACI, I think, goes down to 8 that you could give to your clients. They're not freely accessible. They're actually quite expensive. So I wish there was a more freer version. But then I want to talk about our projective tests. So there's been some research on their lovely Rorschach with this population as well. And I included this here because we talked a lot earlier about fantasy proneness and how people who have high fantasy proneness are actually probably, like, DID don't have high fantasy proneness. So you would see this on a projective. Their like difficulty kind of reality testing or high fantasy proneness and how they respond to the ink blots. And research has shown that there's distinct profiles between DID and PTSD and BPD, which is pretty interesting. This is not a super accessible instrument, though. It requires a lot of intensive training for that. So a slightly more accessible one would be the TAT, which again, it's more about projective, generating narratives. You could do more of a qualitative analysis, get some of that perceptual quality there and fantasy proneness there. But I want to highlight projectives as well for people who are concerned about malingering, in that it would be really hard to manipulate a projective if you're not like answering questions. You tend to get a more like a less defensive profile. Not always, but it's helpful. And then there's actual malingering tests. Yay. So there was this research group led by Brand is the name. You'll see him in our resources, or her. Actually, I don't remember that person in their resources. And I think they just decided, they're like, we're going to test every instrument on a DID population. So, and I love that for them. That's a really cool, special interest. So a lot of this comes from that research group of like, they just put every test out there, be like, can we distinguish between these different disorders? Can we distinguish between simulated DID versus actual DID? And so they've established that 2 of these instruments are pretty good at doing that. So the TOM and the MFAST. The TOM is going to be like a visual recognition test. It's like essentially a memory test that's pretty easy. Like even people with, like brain injury or dementia can do pretty okay on it. So if you do poorly on that, it's like, you're probably faking. And then the MFAST is a forensic assessment of symptoms. They recommended that it's really helpful to distinguish simulated versus genuine DID, but they recommend increasing the cutoff for more sensitivity. Whereas the structured inventory of malingered symptomology, they said it's sensitive, but like low specificity. So it's not great at identifying DIDs specifically. So those are some instruments to consider. And then I want to highlight some important rule outs before we switch to talking about treatment. So one is our classic, OSDD, other specified dissociative disorder. Criterion 1 is that there's chronic recurrent syndromes of mixed dissociative symptoms. So this is for that individual that like maybe has some of these traits and maybe has some of these experiences with DID, but maybe their trauma occurred much later in life. So it wouldn't quite fit that early personality fragmentation model. Or maybe they don't quite fit the other symptoms of DID, but they do have some of these traits that are clinically relevant and important. So we put them in this category. And I even had clients kind of say, like, I think I have OSDD 1. And I'm like, I'd love that for them, that they're like, kind of have this openness of like, maybe my presentation doesn't fit exactly perfectly in these categories, but I think this might capture it. They have diagnoses related to coercive persuasion, aka like brainwashing, acute reactions to stressful events, as well as a dissociative trance. So maybe your client has some of these distinct dissociative experiences, but it's not quite DID. I also want to highlight neurodivergence, like ADHD and autism. I could think of one exception, but almost every single person I've assessed for DID had autism. Almost all of them. And so I was like, what is that connection? What can research say? So there's obviously going to be like potentially autistic individuals just have higher likelihood of traumatic experiences or attachment disruptions, just based on the nature of the disorder and depending on the developmental disability. There's also autistic individuals just in generally experience dissociation from other traits of autism, like sensory overwhelm. They might have more like alexithymia or difficulty articulating their emotions and experiences. So describing their internal experiences can be different compared to a neurotypical population. They're good at, masking in different environments. And so I found this, there's this, I guess, influencer, if you want to give them a label, who they have autism and DID, and they kind of describe their experience. They're called Autistic Selves. They have like a YouTube channel, Instagram. And so this person writes, I believe I developed different alters mainly as a way of coping with being autistic, of growing up as an undiagnosed autistic, and as a way of trying to create order in a world that I found unbearably chaotic and disorganized. As an autistic person, I like my world to be neat, predictable, and manageable. I have a whole system of interconnected alters, and each one has a different role and a different function, enabling me to live in a complicated and sophisticated life without getting too overwhelmed. So it's interesting how that might be an adaptive response to, as I said, being neurodivergent in a neurotypical world, or it might just be a way that they experience their inner state, and it's not necessarily pathological, or it might be different than our definition of DID, but that's how they've learned to get by in life. So I highly recommend looking at that. Content creator said there's not a lot of research connecting the two, but I said just experience, just anecdotally, I said every single person, except one that I could think of, had autism that presented with some DID symptoms. And then ADHD, they made some connections to in the research where people with early childhood trauma have ADHD-like symptoms in terms of like attention and hyperactivity and impulsivity, right? And so maybe that's like a misdiagnosis of early childhood trauma, especially maybe in certain populations. So, and then another rule out is seizures, because we kind of talked about like conversion disorder symptoms and cataplexy. It's like, okay, maybe there's something more neurological. Someone had this question, where do we find the profiles of OSDD? And I'm not sure what that question is asking, like what profiles. The descriptions of OSDD are in the DSM and like what all of those 4 criterion are. But in terms of like some of the instruments, like the MID will have specific OSDD profiles and some will not, if that is your question. So sorry, I don't understand your question. Let me pause here and check on if there's other questions we missed in the chat. And it looks like I think we got all of them. So Triona's going to discuss treatment.
Yeah. All right. So treatment of DID. So evidence states that there should be kind of a phased approach to treatment. And really, I feel like this phased approach to treatment is something that like we all generally do anyway. So the first phase is just focusing on safety, stability, and symptom reduction. Second one is actually going into the trauma and processing what the client has been through. And then the third phase is helping the client basically adjust to the new sense of self and their well-being. And I'll go into more detail with each one of those. So the first one, phase 1 is the prep. So addressing the client's safety from others or from themselves. If they're doing some self-harm or if they're, still experiencing some trauma from other people, addressing possible risks in their environment if they're still in a traumatic environment, and then addressing possible destructive alters. And so like we talked about, there can be some alters who mimic the perpetrator. And so addressing some of those alters and working with those. So it's basically just to stabilize the client in their environment and themselves. This is the foundational work we need to do before we can ever go into any of the trauma work. This is to reduce symptoms and being able to go into that trauma work. So there's lots of different ways we can do this. Obviously doing some psychoeducation with the client about what their dissociation, what dissociation even is, and then talking to them, like I said, using that dissociation chart that I use so that they are able to talk to me about how it works for them. I'm able to talk to them about how it works for them. I did the mid with one of my clients. I did the full version. I actually had to do a lot of psychoeducation about like, yep, this is what's happening for you. You actually do have DID. And so, and talking to her about what that looked like for her. She knew it, but she needed the mid in order to like help her actually recognize what was going on with her. We can do some CBT skill building stuff, as well as impulse control if they do have some of those parts or alters who go out and impulsively do things, if they do that as well. Emotional regulation with DBT if they're getting overwhelmed a lot, or interpersonal effectiveness, because oftentimes with DID they're going to have some trouble interacting with people in their lives, whether it's, spouse, kiddos, significant others, family, whoever it might be, coworkers, right? Excuse me. And then we can do some ego state work. So I know there's a couple different versions out there and people use different ones. I love to use internal family systems, or IFS. That's kind of what I know, what I'm trained in, and what I'm comfortable with. And so within internal family systems, basically the structure is setting up this kind of system, this internal world, and then getting to know all of everyone who's in that system. Getting to know, and like Laura said, not every alter has to have a distinct role and everything like that, but we try to just get to know them a little bit to try to get kind of like Laura said too, we're all on the same page. We're all working together instead of all of these alters or ANPs trying to fight to front, and it causes a lot of chaos. So with internal family systems, we try to get everyone on the same page so alters don't feel like they have to take over the system. And then something I use quite a bit is Jim Knipe. He uses this scale, and it's called the back of the head scale. And I use this with clients so they can let me know where they're at as far as how much they're in the room with me versus not. So he uses this. This is kind of like, yep, I'm here. I'm fully present with you. This is maybe 50%. This is, I'm not even with you. Like which they may not even be able to do when they're in the room with you. This is like, I'm on the way out. I also use, I brought a little basket of treats here. But this is also something I use quite a bit with maybe my adolescents or kiddos. So this is like, yep, I'm with you. This is like, nope, I'm getting farther and farther and farther away from you. So I really like this little stretchy guy. I also have this, this little giraffe that I will use. And so this is, yep, I'm here, I'm fully present. Oh, I'm fading. Yeah, I'm not here. I'm not with you. So I really like this little guy too, to help me understand where they're at, and so that we can do some things. And those things would be grounding techniques. We have to go over grounding techniques quite a bit with our dissociative or DID clients. And so there's lots of different grounding techniques. Everyone has preferences and what they like to use. So the first one that I like is called the 4 elements, and it's just earth, wind, water, and fire. So earth is basically just asking the client to feel the ground under their feet. Feel the ground under your feet, feel the chair against your back, feel the couch or whatever supporting you, just having them connect to the earth. Even sometimes having the client kick off their shoes and just feel the carpet under their feet or whatever it might be is helpful. So that's ground. Water is having them concentrate or really notice their breathing. So doing whatever breathing technique you like to use, whether it's square breathing, triangle breathing, 4, 7, 8 breathing, whatever that looks like, having them do some conscious diaphragmatic breathing. And then water is, it sounds kind of strange, it's making some saliva, because oftentimes when clients are not grounded, their mouth goes dry. And so it's making saliva. So whether that's having them like rub their tongue across their teeth, grabbing some water. I also like have little mints or candies in my office that I just am like, okay, like, do you want a mint? Let's have you pop in a mint, because it will actively make some of that saliva and tells the brain and the nervous system like, oh, okay, we can be here, we're okay. And then the last element is fire. And so fire is just getting them back into their frontal lobe, basically. And so I will often ask clients, okay, what's the capital of Nebraska? And I don't know. I mean, I think it's Lincoln. I don't know. But and clients will be like, it takes them a second and it gets them back in their brain. And they may be like, I don't know. Cool. You don't have to know. I just want you thinking. Or name as many countries as you can that start with the letter A. Or what's 8 times 12? I don't know the answer, but like it gets them thinking. You can even ask, what are you doing later today? What did you do this weekend? Something to get them kind of back into the present with you. So that's the 4 elements. The medicine ball, the client who I was talking about who had cataplexy, I would actually, in session, while we were talking about her trauma, I would actually have her sit on a medicine ball, or a balance ball, not a medicine ball. Anyway, a medicine or a balance ball, so that she had to stay engaged. She couldn't slump over because then she would fall over. So it was her body had to stay engaged and balanced on that ball. I've got lots of fidget toys that I use with clients. Just to help them stay in the moment. It's got some little rocks that they can rub, lots of different fidget toys. I will often throw a ball back and forth. So I've got this fun little koosh ball that I'll throw back and forth with clients, and I'll have them use their dominant hand, and then I'll have them switch to their non-dominant hand, because it takes more concentration, it takes more effort for them to have to engage their body in that way. Let's see what else. I've got different sensory stuff. So I've got these little cards that have different textures on each one of them that I will have clients just feel and kind of tell me what they feel like. Let's see, any sort of reorientation is going to be great. And so just, notice 5 things in the room that are blue. Is there anything you smell right now? Anything that's good, or if there's someone in the next room who slammed a door, oh, did you hear that door slam? I think that's going to reorient them to being in the office with you. Or even reminding them you're here now, you're okay, you're safe, whatever that might be. And then any sort of movement stuff as well. So actually having them stand up, or having them walk around the room, or having them just doing any sort of movement stuff. I have a couple clients who bring, they bring their dogs with them. And so that's helpful. Another little toy that I use is kind of this little stacking doll. And that's really good for my kiddos. I break it up and I'm like, okay, I want you to put this back together. And it takes a lot of effort and a lot of concentration for them to have to match up the right piece, top and bottom. So that's really helpful. I love that. So those are some grounding techniques, but I know there's lots out there and we all know quite a bit. Let's see, I'm just kind of looking at the questions here.
Yeah, there was a question about getting training in IFS because the Institute has like a lottery system and kind of expensive.
I know people say sometimes that PESI can mean messy, but I have gotten a few through PESI, some of these IFS trainings. So, but there's also, there's a recommended reading list at the end of the slides here. And a few of those are some of the books, the IFS books. All right. And so, yeah, there's lots of different, once you get into the work, once the client is good and safe, they're able to kind of stay within dual awareness with you. They're able to stay in the room with you. A couple different modalities that can work with these clients. So we can do prolonged exposure. So having them, excuse me, imaginarily or in vivo, expose them to some of that trauma, to be able to look at it, confront it, and deal with it that way. There's also TFCBT that we use more with adolescents, that trauma focus, where we focus on it's not your fault, replacing negative cognitions, giving them skills, different things like that. And then there's cognitive processing therapy, which we use more with adults. And a lot of that is psychoeducation, dealing with their thoughts and their emotions around the trauma that they went through. Psychodynamic therapy, which of course is based on like, how do we take our past identity and how it influences our present. And then EMDR, and EMDR is one that if you're just basic trained in EMDR, they're going to be like, be very careful in doing this. Don't do this unless you have more specific training. So there are actually a lot of advanced trainings in EMDR dealing with DID clients and dissociation, because with trauma, you're going to get dissociation no matter what. And very probable, like we saw in the statistics, that you're going to get a client who is DID. And EMDR is based off of the adaptive information processing model, which basically states that trauma or different things that have happened in our lives are stored in our brain maladaptively, or what's the word I'm looking for? Undigested in our brain. And in doing the work and doing EMDR, it allows the brain to be able to process them and come to adaptive conclusions. So those are some of the different modalities that are evidence-based for individuals with DID, whether adolescents or adults. And then integration. So like Laura said, the goal is not always that integration is going to happen. And actually integration, if we think about what integration actually is, we ask all of our clients to go through some sort of integration. So it's basically that, how do we look at the history, look at what you've been through, and kind of integrate it into who you are now, and look at it and with some sort of acceptance, lack of fault, more forgiveness or empathy towards self. So we have to integrate what happened and who we are now. So integration is something everybody does. So there's partial integration. This basically means that individual will keep some of those or retain some of those certain alters. And this could be because maybe the person doesn't need to be fully integrated. Maybe they need to keep some of these alters to help them if there's some of those helper parts. Or maybe there's fear in letting some of those alters go because they are needed, or they don't want to lose them. They don't want to go through the grief of getting rid of this alter. So lots of different reasons why a client may not want to fully integrate. And then full integration is obviously that like all the parts are combined into core self. But full integration is not something that is always going to be permanent. Full integration can change if like the client experiences another trauma. They've learned to dissociate so well, and their brain is used to creating these alters that they, maybe they're fully integrated, they're doing great, they're going along, and then a trauma happens and they're going to go back to their coping of like, I'm going to create an alter to deal with this or to hold on to this trauma. And so it's very common for individuals who are fully oriented or fully integrated to not remain that way. That's not necessarily a bad thing or a good thing. It just is. So clients, even if they're fully integrated, are still going to maybe need to come in and do some work with their alters. And then, yeah. And then the last slide. So I don't know if you guys have had this, but had an edgy teen say that, oh, I have multiple personality disorder. And yeah, so how do we react not like this and not roll our eyes, cross our arms and go, okay, whatever. I think it's so important just to listen to them, just to hear what they have to say, hear what their experience is like, validate what they've gone through or some of the traumas that they've experienced. So listening, validating, and then gaining some understanding of them and their lives and their experiences. And just like Laura was saying, it's so important to validate their identity development, especially in adolescence. They're going to find different things to explain their identity and how they're developing it. And like we've seen on TikTok, this is a nice go-to for them. And then educating them about like what dissociation looks like, what DID is, and not to give them too much information about this so they don't glom onto it like on TikTok, but actually educating them about like what their experience is, what trauma is, how memories are stored in the brain, like lots of different psychoeducation that we can give to them. So I think there's some questions in the chat here. Let's see.
I think there's just sharing of resources about IFS. So definitely, and we have lots of our resources here, some of the books that Triona was referring to. And then we have our resources at the chat, and just like a slight, that we're wrapping up, like a little plug. If you like this talk or things like it, we have our DBT skills course that is a fully online, lots of videos, lots of content, and it's on a discount right now. So we highly recommend it. And, in this talk, we talked about how skills work is really important in trauma and dissociation. So, and then we have an upcoming talk that is also, sponsored by and approved by all of these organizations. If you want to come back to these kinds of events, we're having an upcoming talk on ACT and internal family systems and about burnout and compassion fatigue. There we go. I'm trying to fit it all in the last minute. Yeah, I feel like we could talk about this all day. I so love that Triona joined us today, and I thank all of you for taking your time out of your Friday to join us today. Yeah, thanks everyone.
Thanks, guys.